Director of Infection Control Program and Antibiotic Stewardship Program. Dr. Moran is an infectious disease physician with internal medicine and infectious disease training, physician scientist experience in over 10 years in general and neurosurgical infectious diseases clinical practice, with additional training and experience in directing hospital infection control and prevention and antibiotic stewardship program. We welcome her tonight as an expert in the field relative to not only infectious diseases, but also working with us through our Healthy Verify certification to ensure that we're doing everything we possibly can to mitigate the risk of the spread of COVID. Welcome, Dr. Moran.
Thank you. I don't know do you have any questions for me or?
Yes, definitely. One of the things I know that has been a bit of a concern, or a large bit of a concern, is when we're considering coming back to school and the conversation around masks. And I know there has been vast conversation since we began this journey. Can you talk a bit about that, what your perspective is, and in your experience, what the best approach would be for reopening our schools?
Sure. Masks, among all issues related to COVID, has been the most controversial, and there's good reason for the public in general and even among medical providers to be confused based on the fact that the initial information was rather contradictory, and the recommendations that CDC and WHO gave at the very beginning of the pandemic came from a lack of knowledge, given that the virus is such a novel condition, and two, based on scarcity and the need to preserve PPE for healthcare workers and front line workers. But now we know much better. So there is clear data that supports the utility and efficacy of non-pharmacological interventions for prevention of transmission of COVID-19, i.e. masks. The most prominent study was published early in June in the Lancet, and it was a large meta-analysis that included 176 studies, including, of course, COVID-19, SARS, and MERS. And the bottom line results are these. When everyone wears masks, including symptomatic patients or asymptomatic people and healthy people, the risk goes from 67% of transmission when nobody's wearing masks to 6% transmission. So the results are certainly significant. They were nicely statistically significant in the study. When it's coupled with other interventions or mitigation efforts like hand washing, social distancing, cohorting among children, the efficacy is even better. There is data also from modeling studies that comes from Washington and New York, where the investigators actually looked at modeling the effect of instituting mandatory mask and universal mask wearing in the public. And there was a quick decrease on mortality that was statistically significant. This is both based on actual data and mathematical modeling that led to that conclusion. When I say masks, please make it equivalent to cloth face coverings, which is what the CDC and WHO now recommend. So it's pretty clear, and evidence is very convincing that widespread or massive mask wearing in the public is effective in decreasing the transmission of COVID-19 in the community, and certainly it can be translated into schools.
Thank you, Dr. Moran. One thing that I heard you say, a word that is becoming universal in our world, is cohorting. Can you please share the perspective around children traveling in cohorts and groups, and what that does for mitigation?
Yeah, so the idea of cohorting is to decrease the number of exposed individuals should there be a symptomatic or asymptomatic case. And before I go any farther, I want to clarify something that is very likely public knowledge, but I just want to be sure everyone is aware that now there is confirmed data of asymptomatic transmission of the disease. In other words, people who are going around feeling well and doing well can have the same amount of virus in their respiratory secretions, which includes saliva droplets, nostril droplets, etc., than a person who has full-blown disease. And that means that the virus is equally transmittable whether the person is symptomatic or not. Hence the recommendation of masks. And then let's go back to cohorting. So the idea of cohorting is to prevent or to decrease the number of exposed people should there be a case. So for example, if a child is asymptomatic and has the infection, but it's not showing any symptoms, the child will remain with the group of whatever number you determine is feasible in your schools, 10 or 15 per classroom, or 15 to 20, etc. Let's pick 15, so that student will only expose those 15 with whom she or he stays most of the time during the school time. It is so the applicability of cohorting, of course, varies depending on the grade level. For example, in high school settings, it's probably less practical to practice cohorting as opposed to lower levels like pre-K or elementary schools, where there's not much mobility in between classrooms for academic reasons. And so essentially, the point is you want to expose the least possible should there be a case in the school.
So can you share the lessons that I've learned from other countries that have come back, had students out of school or actually never even closed schools, and what they have found relative to transmission rates and things such as that between children and adults?
Correct. And now we have data from not only other countries in the world, like you said, never closed or opened up a month or two ago, but also we have data from the United States. So I'll start talking about the United States. So the CDC, through its medical journal, MMWR, put a report late May, early June, showing that children, even though so children are underrepresented among the cases of COVID-19. And if you look at the population, at the population level, children constitute 22% of the American population. Yet, there are less than 2%, rather 2 to 5% of all the COVID cases described. And not only that, but the percent of cases among children, of COVID cases among children, varies depending on the age group, such as younger than 10 tend to be less percentage of COVID cases than 10 to 18 ages. So it tends to be like elementary school children are less likely to get infected. Other countries showed exactly the same. And places like, and I can give you numerous examples, and I'll be happy to share with Dr. Hargrove some of the papers we reviewed for other schools. But essentially in China, for example, children are half as likely to get infected than adults from a single contact. So a case of COVID-19 is more likely to transmit it, is twice as likely to transmit it to an adult than to a child. Then Iceland actually did also a seroprevalence study where they actually measured antibodies at intervals. And it was, they actually captured 10% of their population, which is a major endeavor, although the population is not that big, but it's still a major endeavor. And what they found is that 6% of children were seropositive as opposed to 13, 17 among adults. And I can give you multiple examples from China, Japan, South Korea, etc. But the data from the United States is pretty compelling in terms of a small percentage of children compared to adults will actually get infected. Okay, so when children get infected, children tend to have less severe disease. This is also data from CDC and data from a case series from New York and Canada, where it is noted that the rate of hospitalization is about 4% for children compared to 15 to 20% among adults. And when you look at the children who were hospitalized, the vast majority, over 80% of them, had some sort of medical condition, including obesity. As a general statement, a healthy child, it is less likely, if infected, less likely to end up having severe disease that requires hospitalization than an adult. And then also there's concerns about uh, collateral diseases or associated diseases with COVID-19. And the most famous one, or the one that got the press the most early on, is that Kawasaki-like illness. And I've also looked at the data from New York and Washington, the data from UK, and it looks like it is a very unusual event. It's serious, it's definitely serious, but it's very unusual. Just to put it in perspective, of the 60,000 cases of COVID-19 in children as of mid-May, there were about 180 cases of Kawasaki-like disease described. So, the proportion is very, very small. So it's less than 1%. Mortality is also about 0.7% among children. And when I say children, I'm talking 18 or younger from now on. Again, this is data from MMWR. Now, the other concern that we as adults, and I'm sure you as educators and teachers are aware of, is how likely, so we know that children are less likely to get infected, are less likely to get symptoms and to get severely sick, but how likely are they to give it to us adults, especially in the school setting? There are studies that looked at that, and the two that I can mention are one in China, that they followed about 800 cases of COVID-19, including children, and they saw that children were significantly less likely to give it to another child or an adult compared to adults. And then in Denmark did a study also that essentially they looked at all the cases they had for about 4 to 6 weeks early on in the pandemic, and what they found is, when you look at the ages of the primary cases, and then they look at the secondary cases, they saw that cases that were ages 18 or younger had 0 secondary cases. In other words, they did not transmit the disease to any of their contacts, as opposed to adults. And that brings another point that I think is very important, which is, where do children get infected? So children typically, and this is again based on that study in China that I mentioned, the 800 cases that were contact traced, children tend to have or get the infection at home, not in the community and not in schools. And there are experiences from France, as well as Australia, South Korea, where the rate of transmission within school settings is very low. Is not 0. I will never promise you that you will have 0 cases in the school, but it's certainly very low. And there's also, this is actually lay press, it's not a study, but there's lay press put out by NPR recently, where they look at multiple daycare and child care centers taking care of children 14 or younger. And this is typically children of healthcare workers like myself, or frontliners, or or essential workers, who actually, we had to continue working, and we needed to keep kids in childcare. So some childcare centers actually did not close, including YMCA. And there has been less than 1% of cases reported between or among children in those settings. In fact, one of the sites was here in Phoenix. So essentially, in conclusion, number one, children tend to get the infection less likely than adults. Number two, if they get the infection, they tend to be much less severe with less rates of hospitalization. Thirdly, from whom or to whom do children transmit the disease? From whom is mostly adults. Like I said, it seems to be rather a one-way street, where it's adults giving it to children rather than children to another child or to an adult. And also, what I think is very, very important for protocols of isolation and contact tracing in the school settings, the vast majority of children get infected at home, not in the schools, not in the daycare centers or childcare centers. So I think those pieces of information, albeit rather young, because the pandemic has not been going on for even 6 months or barely 6 months, I think it's very strong evidence that children get infected less and that schools are less of a driver of transmission within the community. I must add another piece of information also. There was a study published in in JAMA, in the Journal of the American Medical Association, in early May, looking at why are children less likely to get infected. And the study looked at different ages, and they looked at the ACE2 receptors, which are the portal of entry of the virus. And these, the receptors that allow the virus to enter the human cells are less in quantity in children 10 or rather younger than 10. So 9 or younger, those children express less of these receptors in their nostrils. And so they are less likely for that reason, among others probably, to get infected. It's a little different story in children 10 to 18. They tend to be more infected more than children younger than 10. But even so, when you look at the numbers compared to adults, you can tell that 18 or younger, they get infected much less. And one more thing, just to put it in perspective, if you like numbers. So the average cumulative incidence of COVID-19 among adults is 400 to 500 cases per 100,000 people. Children younger than 10 is 50 per 100,000 people. So that's 8 to 10 times less than the average adult. And children between 10 and 18 is 100 per 100,000. So that is 4 to 5 times less than the average adult. So even though, again, you know, between 10 and 18, they tend to get infected a little more than the younger than 10, still it is a fraction of what the average adult infection is.
Thank you, Dr. Maria. Those are really important points to consider when we talk about reentry back into our school buildings with our kids and with our adults. One of the questions that I know has come up would be, what would happen if we had a child or an adult in a classroom or in a cohort who was tested positive?
Well, so the Maricopa County and the ADHS has, and the CDC, of course, has guidelines. In 2 other schools that I am a member of the advisory committee, we have recommended that, provided that we have other mitigation efforts in place, especially universal mask wearing and hand washing and social distancing as possible, and keeping people at home, sick people and sick children at home. We are not going to close classrooms when a case has been detected within that classroom. We are certainly going to send that child home and keep the child home according to the return to school guidelines. And we're going to notify parents of the potential exposure. But because the information, the data suggests that the vast majority of children get infected at home, we don't consider classrooms a high risk exposure, provided again that we have all those other measures to the best possible implemented. And one of the other schools I am advising to is a pre-K through 8th grade. So I think it overlaps a lot with your population of interest. And same for high school, for the high school that I'm advising or helping with, we're also doing the same. So we're not closing all the groups where that case was, but we notify the parents for monitorization of symptoms.
Thank you. So I just, in fact, I had an opportunity to hear a panel that you were on most recently, a webinar that you were on. And one of the conversations or one of the points that was made relative to exposure is how long was the exposure, what were the set of circumstances. Can you talk a little bit about that,
Sure.
please?
So the definition of close contact is 15 minutes within 6 feet. And that definition is by CDC and ADHS, and it has to do with the dynamics of droplets in terms of the distance and how readily transmittable the disease is in terms of the time. So any exposure is a product of time by distance. Now, obviously, in terms of time, there's no class that will last less than 15 minutes. So time is a problem in terms of classroom exposure. But again, that does not, so just the statement of what the definition is does not include the nuances of other measures like masking. And I'll give you the example of the healthcare setting. So in the healthcare setting, it's hard to really socially distance. When you take care of a patient, a lot of times we doctors and nurses are closer than 6 feet for longer than 15 minutes. But we're all wearing masks and surgical masks in the case of healthcare setting, and N95s when we actually take direct care of COVID patients. But in other places, like the hallways, the offices, etc., we're all wearing masks, even because most of the times it's hard to keep social distancing. Yet the transmission, at least in the hospital where I work, and one of the panelists you heard also from Mayo Clinic, is about 1%. So we healthcare workers rarely get infected in the healthcare setting. And it has to do, again, mostly with masks because it's, a lot of times it's hard to keep social distancing. So I trust that when you maximize other mitigation efforts, your risk, the level of risk of that exposure in classroom will go low, will be really low.
Thank you. I appreciate that piece of information. Avondale Elementary School District will be moving forward later on this evening with the recommendations to our governing board, and one of them certainly is going to be universal mask wearing for children and adults. And so while I agree with you, social distancing is not always 100% possible. However, we know that when we're in situations when we're closer than 6 feet with one another, that masks are expected for everyone as well during transitions and things such as that, as you said, in the hall, that type of thing. We don't have halls that are 12 feet wide. So we do need, right? We were not made for those. So
and the truth is, when you have little kids are among the most socially interactive children and humans. So I don't have to tell you, you're the expert, but it's going to be hard not to avoid kids wanting to hug each other or play with each other. So that's where cohorting, masks, symptom screening will be really important. So it's a combination of mitigation measures that actually give you the end product of low risk in the school.
Absolutely. Thank you. One of the things, just to share with the entire team who's listening, because we feel so strongly about our children being able to communicate with one another, but want to ensure that they're safe, we actually have, for our tables, rather than going with desks all facing one direction, we actually have plexiglass dividers in between the children so they can still communicate with one another, but they have the inability to have droplets go across the table and that type of thing. So as they are in those collaborative teaming. You brought up something that I would love to have you discuss with us, and that is symptom measuring. So identification of symptoms. And also, if we could ask you to talk briefly about temperature checking.
Yes.
And what you should be.
So so I'll start with the symptoms. So I think it should be an effort in educating everyone in the school, adults and children, and educating families about awareness regarding symptoms at home. Nobody knows a child better than mom or dad or caregiver at home. So if you notice that your child is not quite himself or herself, keep the child at home. I'm sure the school will facilitate distance learning strategies that will allow the child not to fall behind, and then measure the temperature at home. So what we're doing in one of the schools I'm advising is we are empowering the families to do the health check at home before the child even steps in the bus or comes to school. So we allow for even less exposure if the child is sick that day. in the high school that I'm advising, we have decided not to do daily temperature checks at entry points in the school for multiple reasons. There's a medical reason, which is depending on the series that you look at, as little as 30% of children will have fever as a symptom of COVID-19. And some series show 50% to 60%. So that means that if you rely on fever as the solely criteria, you're going to miss 40 to 50% of children who actually come sick to school and have nothing else but fever and maybe a little of undetectable malaise. So that's one reason. The other reason is logistics, which has to do with the fact that everyone has to be in school between 7:30 and 8. I'm sure most schools are like that. So just imagine, depending on the size of your school, the school I'm advising at is 1,300 students. Imagine 1,300 students trying to get into the school, even if you do 6 different doors. That's 200 people a door, and then it's a bottleneck, and it's hard to implement social distancing when you have everyone trying to get to school at the same time. That's reason number 2. Reason number 3 is exposure of the adult who will be screening the children. Remember, you're screening potentially sick children, so the adult will be potentially exposed, and it will require PPE, etc. So for that reason, we have decided in one of the schools not to do temperature checking at the school, but actually empower the families to be responsible and be aware of those symptoms and check the temperature at home before they even show up.
Thank you. I appreciate that. In Avondale, actually, we're going that very same route with clear language in our our parent-student handbook for, the empowerment of our families and affirming that their children are well when they send them to school. We have the same practice for our adults, our staff, that the expectation is that they're self-monitoring and making sure that they're coming to school symptom-free. And if they're not feeling well, that the expectation is to stay home and get better and be well, and certainly protect others. We also, obviously, if a child or an adult were to come to school and became ill during that time, we also have making sure that there's an opportunity for them to be able to rest in a quiet place without being in a situation where they're either getting worse from someone else or being in a situation where someone else could possibly be infected with whatever they may be ill with. Mm-hmm. So those safeguards are definitely in place in Avondale. I do know, Dr. Moran, we do have several questions that we have from our community that we'd like to open up at this point, if that would be okay with you.
Absolutely.
Thank you. I want to share with you also, just with the whole team, just as a reminder, that Dr. Moran has been working with us with the Healthy Verify certification process. Our district office has already gone through the process and does have that certification, which means that we worked very closely with Dr. Moran and her team to develop processes and procedures that mitigate the risk and keep our staff and community safe. Those same procedures are now being applied to the school site, and actually we have our walkthrough tomorrow to be able to process through our final pieces around that, so that we are ready to receive our staff and our community as soon as we're able. So we're really excited for that and appreciate your expertise, Dr. Moran.
My pleasure.
So,
could I ask a quick question? I just wanted to clarify something, Dr. Moran. There was a study, I just want to make sure I heard this correctly. A study that says children are not likely to transmit the disease to adults. Is that correct?
They're less likely.
They're less likely to transmit the disease.
Correct.
And can you tell me how many were in that particular study?
The study in China had 800 contacts. The study in Denmark had 56 total initial cases, including children.
So 856 total about?
Correct.
Okay. My other question for you is, when we said that the vast majority of COVID patients that are 18 and under get that from home, not at schools. My question on that is, since COVID started here in the United States, we haven't had school. So where were those studies taken at? Were they taken at countries that didn't down the schools?
Correct. And not only that, but there was one that actually had what was one of the very first ones, came from China, because at the beginning of the pandemic, there was transmission in the community, yet China had not gone yet into lockdown. So there's one in China. South Korea didn't quite close schools. And then there's also, although this is not a scientific study, but a lay press release that I'll be happy to share with Dr. Hargrove, that talks about the low number of cases in daycares here in the United States.
Okay, I just wanted to clarify that. Thank you.
Absolutely.
So, Dr. Moran, a couple of the questions are around masks. And so one of the questions would be the length of time for kids wearing masks. I think I can safely say that there are times during the day that children will be socially distanced and will be able to take off their masks and have respite from that. But very specifically, they were talking about, what about children with asthma or even some lung disease, that type of thing?
Yeah.
Any thoughts around that?
Yes. So if you look at the guidelines from CDC, CDC very nicely says that mask wearing is encouraged, especially the older the children. And let's go back to that study I told you about, where children younger than 10 are less likely to get infected and less likely to be infectious as well. And also the percentages in the MMWR report. So the data, so the recommendation is vague on purpose, because for two reasons. One is there is evidence that the younger the child, the less likely it is or the less frequently the child less frequently the child gets infected, number one. Number two, developmentally it's harder to keep a 6-year-old wearing a mask for 7 hours, different from a 16-year-old where you can, they can handle that. And not only that, but the younger the child, probably the less symptomatic the child is and the less likely to transmit. So what I'm saying is, do your best to have your students wear masks, especially your little students wear masks, especially when there is no opportunity to do social distancing. Obviously during lunch and perhaps outdoors playing, it would probably be safe to skip the masks for a short period of time. But if you have, during moving around the campus, etc., so instances where social distancing is hard for a short period of time, you can have the students wear masks. Now, going to the question of students who have asthma, so the recommendation by pediatricians is that asthma that is well controlled, there is no contraindication for children to wear masks. Much debate has been has happened around the fact that it's hard to breathe in masks. Well, turns out what you're talking about is cloth face coverings, which should be nicely fitted, but not tight, and should be comfortable. So it should cover nose and mouth, but it should not be tight. And so that should allow, with some adaptation, for the child to get used to it. Now, if you have a child who has a lung condition that is not under control and the child is symptomatic, that child does not belong to school. That child needs to be home. Anyone who has respiratory symptoms should stay home and contact their medical provider. And data comes also from adults with COPD, emphysema, etc., unless there is an exacerbation of such conditions, in which case the adults should seek medical attention. There is no contraindication for masks.
So another question, again, on masks is around claustrophobia. So a child who suffers from that.
Yeah.
I think it goes back to the age piece that you're talking about and individual sets of circumstances.
Yes, definitely. And I do understand that there may be children with conditions such as autism, for example, that will have sensory issues that will make it really hard for them to wear masks. I'm sure with consultation with their provider, you should be able to provide exemptions to those children. But I do not foresee that being the majority of children. And you know, every effort should be made to facilitate mask wearing within the within medical reason. So again, the masks are less stringent as you go on the younger population of children.
Thank
And then
you.
also another comment is it's a matter of getting used to it. And this is good for adults, teenagers, and little children. If we all remembered the first time we wore shoes, it would probably not be a pleasant experience because there's nothing like walking around bare feet. So we just have to get used to it. It's like another piece of garment. And that leads me to another point, which, you know, there's also concern about how hygienic it is to wear a mask for such a long time. And again, you should treat it as another piece of garment. You should change it. Cloth masks should be changed at least once daily and washed once daily. It's just like, you know, after going to the gym, you would want to, you know, wash your gym clothes. Same with masks. And there should be no risk of infection for wearing the same mask for many hours. I can tell you, we healthcare workers do it for hours and hours. My record has been 16 hours. Obviously, I put it down to eat and drink, but you know, it's safe from the infection standpoint.
Thank you. And I think you're hitting a very important point of training. And we've heard of, you know, gosh, how do you possibly, in fact, a lot of the comments are about how, you know, how do we make sure that kids keep them on and that type of thing. It is going to be a habit of mind and a habit of action. And so, and those will be all part of our training pieces. We do have a question about, from one of our communities asking, CDC just released data that showed Black and Latino individuals are 2 to 3 times more likely to contract and die from coronavirus. What should be done in our district to protect our vulnerable population?
Yes, education is key. So far, most of the explanations as to why, and I'm Hispanic myself, as to why Hispanics and African Americans are more susceptible have to do with the same factors that make them more susceptible to chronic diseases like diabetes, hypertension, obesity, etc. And in the case of COVID-19, there are other factors also, such as the fact that many of us Hispanics are actually in the workforce in services jobs, first line jobs, essential jobs that puts us at higher risk for getting the infection, bringing it home. We also live in multi-generational, slightly more crowded settings or households. And so there is higher risk for transmission, particularly within the household, to high-risk individuals such as elderly. So education and prevention and having them wear masks in the community will decrease their risk. Pair that with hand washing, which is very important, and you have an even better effect. But yes, the data that you are quoting is absolutely true. And here in Arizona, my own experience, I would say 90% of the patients I'm treating right now in the hospital are Hispanic.
Thank you. Another question comes from, again, our vulnerable population with children with students with autism and developmental disabilities, high contraction rate. That may, you want to respond a little bit to that as well?
Yeah, so like I mentioned before, while it's infrequent that children get more severe COVID-19, those who actually get hospitalized or get to the ICU have 80% of them have some medical condition. So what we want to do is a community-wide effort. So within the school, institute as many risk mitigation measures as you can, educate families in terms of keeping sick children at home. I can't stress that enough. I think another aspect is also vaccination, because in the fall also comes the flu season, which is, by the way, highly transmissible within children and within schools. We just don't see much because there is widespread vaccination. But because of COVID-19, the percentage of vaccinated children for other diseases, not just a flu, has gone down because we parents are afraid to take our children to the pediatrician because we're in fear of getting infected in the clinic. So I think, all those issues, educate families in the importance of keeping children at home will protect your vulnerable children. Masks as much as possible, social distancing, cohorting, hand washing will be very important in protecting the others. And this is a community-wide effort. The next part is not just at the school, but what we do in the community is very important, because we adults, we will give it to our children. Children will bring it to school and potentially give it to adults. I think I'm more concerned about your teacher than other children when children come infected to your school. But again, there is mitigation. Those mitigations efforts will actually, they work, they do work. And like I said, the perfect example is a healthcare setting. Despite a high exposure to patients, we have a really low healthcare setting transmission. So again, I think it is important to educate the families, because anything the families do, anything we do in the community will affect our school. And I want school in business. Children belong to school. And the American Association of Pediatrics, or Pediatricians, actually just put out a document this week, or what day is today? Tuesday. So last week actually where the conclusion from the pediatricians is schools need to reopen because the risk is relatively low, and we can keep it low by mitigation efforts. Granted, it's early in the game. Much remains to be learned about how COVID-19 behaves in children, what the role of children is in the transmission dynamics in the community, and what the role of schools is in the transmission within the school and in the community. But so far, data seems to be really supportive of its safety. But we all have to follow the same protection rules that we do in the school, in the community. Because again, children can bring it to school, and it comes from home. It doesn't come from school. More than 80% of the time, they will come from home. So what your parents and your families do will affect your operations in school. And that I can't stress how important it is to educate them. And that's actually something that at the high school I'm helping at, the high school is doing a really great job sending communications. I'll be happy to share those communications with you. I already talked to Bob Ryan about our meeting today, and Bob is happy for me to share his letters to family. It is super important that everyone cooperates, not just in the school, but in the community.
Thank you, and we appreciate the collegiality with one of the other schools that you're working with. I know that we're cutting short on time. We've already actually gone over time. I do know, I guess I want to reiterate a couple of really key points that I'm hearing. One, obviously, is family and community and staff training and really rethinking how we do things for when children come to school and they have a cold or have a sore throat or any symptoms, that they do not come to school, and that's part of the responsibility and empowerment of our families at home, and how do we keep other people safe. The same thing on our staff side. How do we recognize symptoms? First, early detection in ourselves, but then also if we recognize it, that we act swiftly and mitigate that. The other mitigation strategies that I'm hearing that are so important would be making sure that we have universal masks, and making sure that when we do not have the possibility of social distancing and putting the 6 feet in between at all times, then we are wearing the mask, or we have another mitigation strategy like I talked about with the plexiglass dividers, so that children can communicate but not be in a position where transmission is possible at that point. As well as routines and procedures for washing hands, and building those into the dailiness of what we do, so that it just becomes a matter of course. This is what we do. The other thing, obviously, is we have enhanced sanitizing operations happening at all of our sites, both at end of day, but also throughout the day for touch points, and in between students coming into and out of a classroom. If a cohort of students goes to another class to receive a different instruction from a different teacher, that the space that they were in also then gets sanitized before the next group comes in. couple of key questions that did come up. I know that in our work, and we'll be talking about this tomorrow, we have models of instruction that we're looking forward to present to our governing board after this town hall. And with that, the choice for families to say, you know what, I'm not quite ready for my children to come back. And so I'd like to engage in a distance learning model or flexible model and have them stay at home and have that as closely aligned to what's happening in the classroom as if they were back in a full day model, that type of thing. The other question would be if families choose to go on a full online model, if they say, you know, we have mitigating factors here at home. We have compromised individuals with their health. We don't want to engage at this point, but we want to engage in an online model. We have that option for our families as well. And then the option when we have an opportunity to come back in a full model, whether that be in a hybrid opportunity where it's a couple of days a week with 3 days off, or if it's full day, 5 day back, which would involve having children back. We feel as though we'll have a balance of numbers to have families who choose that model versus families who choose to do the distance learning and let's kind of watch and see versus the online. With that said, I know that in our plan with you and part of our conversation tomorrow is when we're in a situation where we cannot social distance, and whether that be in a classroom or in a bus, the expectation that the mitigation of the mask is going to be our key factor of mitigation, and also hand washing and building those habits of mind. Is that true? I know that was a lot, but does that make sense?
Yes, yes. And I think it's also very important from the beginning, not just education, but set the expectations for parents, and then also respect the hesitation of parents to send children home. I think every effort should be made for children who are vulnerable or who are the members of household of vulnerable individuals to honor their need for staying at home. And regarding setting expectations, as a parent, and a doctor, I want to hear from the school, and I want honesty. So, and the honest statement is there will be cases. There is no way around it. But so knowing that, what we're going to do, or what the school will do, is mitigate the risk of transmission within school. And again, respect the risk assessment of families. You know, risk assessment is individual, is very personal. There's no right or wrong answer. You know, I know there's people who would be terrified to send their children to school. I'm not. I'm going to send them to school. I feel really confident about the measures, the mitigation measures, and the calculated risk, because the stakes are high. The education of my children, I think children, from my standpoint, my assessment, personal, is that my children belong to school. And as long as the school does as much as possible to mitigate that risk, and they're honest with me and telling me, hey, there is going to be a case. And we made a calculation during our talk, which was about 10 to 15 cases at any given time, asymptomatic, will be walking around in the school. But if you have everyone on masks, everyone, you know, separated with plexiglass or socially distanced, is going to be much, the risk is going to be lower. So again, it's very individual, but the data seems to support that schools probably do not play a major role in transmission. And it's more likely that adults in the school, your staff and faculty, will likely get it from one another rather than the child. So statistically speaking, that is the most likely scenario, that if an adult gets it, it's more like in the job, in the school, it's more likely to be from an adult than from a child. But hopefully, if everyone is wearing masks and staying home if sick and washing hands, you're going to have very little transmission.
Thank you. I really appreciate that. Just what you said about our families and our students, certainly we extend that also to our staff. We want to provide opportunity and flexibility to our staff and to our students and families to be able to make the decision that best fits what they need during these unusual times. And so certainly appreciate that and the emphasis on that in education, for sure.
Absolutely, yeah.
Yes, thank you so much, Dr. Moran. I certainly look forward to speaking with you tomorrow around our Healthy Verify team. certificate. I apologize to you. I apologize to our community. I will tell you there are questions we may have missed. We tried to bring them together, but I want to also be respectful of everyone's time. I think that the questions that were asked were really, really important for our community to hear as we move forward in this decision making. And again, Dr. Anna Moran from the Barrows Neurological Institute and Healthy Verify certification program. We're really, really proud to be able to engage with you and to have you as part of our community. Thank you.
My pleasure. Bye-bye.
Thank you. Bye-bye.